This is the esophagus. If a food bolus is there inside, there is a food bolus inside, then only there will be stimulation of peristalsis. Okay, there is stimulation of peristalsis, and those are known as primary esophageal contractions. Primary esophageal contraction. Primary esophageal contraction. And there are secondary esophageal contractions. If the primary wave is not able to clear the food into the stomach, then there are secondary esophageal contractions. Secondary esophageal contractions. Okay, primary and secondary. And in between, there are some tertiary esophageal contractions, but these are non-propulsive. If suppose a contraction is there, it should contract and send the food below. Okay, send the food into the stomach. But here in tertiary esophageal contractions, they are non-propulsive. That means they won't. What is this? What did I mean by non-propulsive?
They don't
Doesn't propel the food.
Yeah, doesn't propel the food. Okay. So just remember this: primary is propulsive, secondary is propulsive, tertiary is non-propulsive. Primary is the first contact. Once you take food inside, when you eat something, your primary propulsive contractions will start. They will just send the food down. If some bits and pieces are left, then secondary propulsive contractions will start. That is the second part. And in old people, most of the times in old people, what is there is without taking any food, there will be some contractions in between. Okay, they are pathological. These first two are physiological. They are pathological. They are non-propulsive contractions. Okay, the same thing. And see here, this question was asked: non-progressive contraction of esophagus are. What is the answer? What is this? Non-progressive.
Tertiary.
Yeah, those are the tertiary contractions. Non-progressive are tertiary contractions. Okay, see here, just this is self-explanatory. Primary, they are the peristaltic waves triggered by the swallowing center. Just remember, they are peristaltic waves. Secondary, they are also peristaltic waves. Its role is to clear the esophagus of retained food. Any retained food is there, it is passed off. And tertiary, it is no peristalsis, no physiology. This is pathology. Okay, and radiographic description is known as. Did you hear this term anytime? Stress by esophagus. Yes, no? Radiology classes are over?
Yes, sir.
Yes, sir.
They are over.
Okay. Did they tell you this one? Press by esophagus?
Sir, it is in aged people it decreases the contraction.
Sorry?
In aged people it decreases the contraction.
Yeah, this is seen in aged people. Most of the times they are in aged people, elderly people, and some neural pathologies. Okay?
Sir, is it presbyesophagus or prebyesophagus? Because it says prebi.
Yeah, it is pressed by esophagus.
Okay.
Okay? Yeah.
Yes, sir. Fine.
So now we'll move on to the lower esophageal sphincter pressures. Till now we have discussed about the peristalsis and pressures in the esophagus. Now we'll move on to the lower esophageal sphincter pressures. The resting pressure, it is 10 to 26 millimeter mercury. Resting pressure is 10 to 26 millimeters of mercury. Okay. So if it is more than 26, millimeters, then it is failing to relax. If the resting pressure is less than 10, What will happen?
More of relaxation.
Yeah,
GERD.
more of, so what will happen?
Good.
Yes, that's
GERD.
it. Yes. GERD will be there. If the pressure is high, if the pressure needed to open the sphincter is very high, that is it is failing to relax. It is not relaxing. Then it is known as,
Achalasia cardia.
yeah, achalasia cardia. High pressure says achalasia cardia. Confusing or is it clear?
No, it's clear, sir, but just slowly trying to understand.
And this also, what is the gold standard investigation of choice for esophageal motility disorder? Gold standard, if they ask gold standard, it is high resolution manometry. What is manometry?
Study of pressures inside the
Pressures in the
esophagus.
esophagus. So, yeah, study of pressures inside the esophagus. What is the pressure in the esophagus? How much peristalsis is going on? What is the lower esophageal sphincter? These are all details which we'll come to know by using a high resolution manometer. Okay.
Okay,
Yeah.
sir.
And now we move on to motility disorders. There are two types of motility disorders. One is hyper and the other will be hypermotility. What will be the other thing?
Hypomotility.
Hypomotility, yes. Okay, yes, simple thing. See, now don't get into complicated things. Just think esophagus is a tube here, muscular tube. If it contracts, food will go down. The sphincter will relax. It should contract, the sphincter should relax, food will go down. But what happens sometimes is this esophagus will contract more. If it contracts more in this region, what will happen? What will be the signs and symptoms? Just guess and tell me. If it is contracting more here in the thorax, so how will the patient feel?
Can you please repeat that? Sorry, I couldn't keep track of you.
Yeah. There is esophagus here. Okay, I'm just asking you, simple, I'm just asking you, if there is hypermotility in the esophagus, normal motility, suppose there are 10 contractions, normal motility. The patient is experiencing 100 contractions, there is hypermotility. What will happen? What will be the presentation?
MSS.
Sorry?
MSS.
Plays into spasm.
Yeah, spasm, one. There will be esophageal spasm. Okay, accepted. So how will the patient present? Why is it so important? Why are we discussing this is, see, because of this location, the patient will have severe chest pain, retrosternal pain. So it will mimic like MI. Okay. So that's why these are important to rule out. Okay. So if suppose a patient will have chest pain, we are dealing with cardiac condition, MI. So if it is ruled out, then we have to think of some motility disorders also. They will also present with same like features of chest pain because of its location. Okay.
Okay.
Yes, no?
Yes, sir.
Yeah. So we'll deal with achalasia first. Now, achalasia, you got a basic idea now. In esophagus, we are dealing with what are the peristalsis, what are the pressures, what are the various pressures in the upper tract, and what is the lower tract, what are the various motility disorders, what are the presentation of motility disorders. How will the motility disorders present with?
Either
Motility
hyper
disorder.
or hypo.
Hyper.
Pain,
Sorry?
chest pain,
Oh, okay.
esophageal spasm.
Yeah. These all symptoms related, they will have pain, retrosternal discomfort, and spasm. Okay. If hypo, single most important symptom, hypo.
Regurgitation.
No,
Re-
that is food is not going below, right? So what will be there?
Vomit.
accumulation. Wait.
Dysphagia. Dysphagia.
Yeah, dysphagia will be there. Hypomotility, the single most important symptom is dysphagia. Okay.
Okay, sir.
Yeah. And now this achalasia is different. Achalasia is, we are talking about the lower esophageal sphincter. It is the normally the lower esophageal sphincter should be in contract. It will be open or it will be closed normally.
It'll be closed.
It should be closed. It should be closed. and there is certain amount of pressure. What is that pressure? It is 10 to 26 millimeter of mercury. That is the pressure with which it is closed. If you want to open it, you have to give the pressure to it. You have to send a signal and you have to open it. If it is even not opening, after the food is there in the esophagus, and if it is not opening, then it is known as eclasia. And there are 3 types of eclasia: type 1, type 2, and type 3. Okay, type 1 is the most common. It is known as classic eclasia, type 1. It all depends upon the pressures in the esophagus. Okay, so type 1 is the most common. It is classic. And type 2 has the best prognosis. It is known as vigorous. And type 3, it is very rare. I have not seen this, and it is spastic. Okay, these are the types of eclasia. Depending upon the sphincter pressures, there are 3 categories. And what is the most common type of tracheoesophageal fistula?
C.
Yeah. And most common eclasia cardia?
Type 1.
Type 1.
1. Most common posterior urethral valve? Come on. Day before yesterday we have read that. Posterior urethral valve. Then what is the sign of posterior urethral valve? Anybody? Just sign?
Reflux.
No. Sign I'm
Backflow.
asking.
Oh, sorry.
Yeah, backflow will be there. That's all correct only. But what is the sign I showed you? I showed you an ultrasound picture of something. K.
Keyhole.
Yeah, keyhole sign. Yeah, keyhole sign. There also type 1 is the most common. Okay. So these are the 3 types. Tracheoesophageal fistula type C. Posterior urethral valve type 1. Eclasia type 1. Okay, remember. Yes?
Yes, sir.
Yeah.
What's the difference between these 3 types?
Yeah, I'll tell it. See here. Type 1, type 2, and type 3. There is absence of peristalsis. This is the sphincter. This is the sphincter here. This is the esophagus. Okay. There is absence of peristalsis. No peristalsis will be there. Okay. Are you following?
Yes.
Yes, sir.
Yes, sir.
Following.
Yeah. And there is no pressurization within the esophageal body. Because of the absence of this peristalsis, there is no pressure at all. Zero pressure. Pressures are 0. And the sphincter pressures are high. Lower esophageal sphincter pressures are more than 26. These are high. This is the features of type 1. And type 2, there will be absence of peristalsis, but the pressures in the esophagus are very high. Because of the anatomy, the pressures are very high. It is more than 30. Pan-esophageal pressurization of more than 30. And the same high integrated relaxation pressure, this is same. High pressures are in the esophageal sphincter, the pressures are high. This is same for both. The only difference is there is no pressure in the esophageal body here. There is high pressure in the esophageal body in type 2. Okay. Clear? My point is clear?
No, I am confused over here between 1 and 2 again.
Yeah, me too. A little confused.
I'll tell it again. Okay. Actually, this is not necessary for us, but I'll tell it for you because you asked. Okay. See, this is the esophagus. This is the sphincter below. In type 2, this is the esophagus and this is the sphincter. There is no peristalsis in both. Peristalsis is absent in type 1 and type 2, negative. Pressures of the sphincter are high in both. Till now it is okay?
Yes, sir.
Yes.
Yeah. But the pressures within the esophagus, are different. The pressures within the esophagus are 0, no pressures at all in type 1. No pressure at all in type 1. But in type 2, there is very high pressure within the esophagus. Is it clear now?
Yes, sir.
Yes,
Yeah.
got it.
Okay. So now you should tell me. So which will have better prognosis once you treat the condition? This is all about the sphincter. Once you correct the sphincter, which will have better prognosis? 1 or 2?
2.
Why?
2 will be better, sir.
Why?
Because
Yes,
there is
2 is
because there is higher pressure within the esophagus.
esophagus. Food
They
will,
food be able
food
to
will move
push
down.
down.
So
Yeah.
here, see here. That's why we tell type 2 has the best prognosis. Very good. You got it. Type 2 is the best prognosis. Okay.
What did we mean by this? Is what we mean by integrated relaxation pressure. Is that so, or is that different?
integrated relaxation pressure is different, but for our sake, this is almost the same like lower esophageal sphincter pressure. In that slide I showed you, right?
Yeah.
Lower esophageal sphincter pressure. See here, this is the resting pressure, lower esophageal sphincter pressure. Integrated relaxation pressure is almost the same with a small difference. So I don't want to go into details of it because it will be a little complicated. It is a mathematical equation, amplitude duration into centimeters. So for our little understanding, I am just telling lower esophageal sphincter is almost the same like integrated relaxation pressure. Okay.
Okay.
Yeah. And coming to type 3. Type 3, there is absence of peristalsis. Same absence of peristalsis is there. There is high integrated relaxation pressure. That is also same. That is lower esophageal sphincters are high. And 2 or more spastic contractions are there here. 2 or more so it is not like absence completely like type 1, or it is not like high pressures like type 2. There is a spastic contraction. Once there will be contraction and they will stop. Once again there will be contraction and stop. So it is known as type 3 is known as spastic type. Okay. This is about the types of achalasia. Clear?
Yeah.
Yes, sir.
So you need to remember only one thing from this. Type 1 is the most common. Type 2 has the best prognosis. Right?
Okay, sir.
Okay.
So exam oriented point of view, that's what we need to know. That's it, right?
Sorry?
For the exam, it's just this type 1 stuff.
Yeah. Exam,
Okay.
they will ask mostly, see, this image they will ask you from achalasia, this image they will ask you, bird's beak, and what is the most common thing. And management
sir.
will see.
Okay.
Okay.
And
So,
just wanted to make a note of all the very important ones for the exam. That's why I asked, sir.
yeah. These are, that's why whatever is important, I will be covering in detail. And the other things, just for completion's sake, we have to cover it, right?
Okay.
Okay. See, this one was asked in the FMGE 2020 only, this was asked. Okay. Is it clear, this image?
Image is fine, sir.
Yeah. This was asked in last August 2020 only. Okay. Okay. So most common age around 40 to 50. It is present between 40 to 50. Most common symptom is dysphagia. And there is a triad like dysphagia, there will be reflex, and there will be weight loss. Why reflex? Can anybody tell me? There is sphincter is there. The sphincter is not opening. So dysphagia is okay. The patient is vomiting whatever he is having. So weight loss is explained. How will you explain reflex?
Does the closure take a very long time, and because of that reflux happen?
Yeah, partly right. See, because the sphincter is always closed, there is a lot of foot material accumulating above. Because of two reasons, there will be reflex. One is there will be the esophagus will be dilated grossly. We call it as mega esophagus. The esophagus is dilated grossly above the sphincter. So that is the foot material there will act like a reflex material only. That is one. And second thing, after so much of after so many years are passed, the sphincter will tonically open up, and so there will be reflux of contents. So there will be dysphagia, there is reflux, and there is weight loss. This is a triad of esophagus. The triad of achalasia in esophagus. Okay. And this bird's beak sign is seen in which investigation?
Barium swallow.
Barium swallow. Okay. What is the difference between barium swallow, barium meal, barium enema?
Time
There are
difference.
different investigations, right? What are the difference? What is the various things?
Time difference.
Very good. It is a time difference. If you ask the patient to swallow and just take it, that is esophagus. If you want, it depends upon the time difference and what is your interest. What is the organ of interest? If you want to only look at the esophagus, just swallow is enough. If you want to look at the stomach, meal should be there. If you want to look at the colon or rectum, what should be given?
Enema.
Enema. Barium enema should be given. Very good. So barium swallow will show a bird beak appearance. This is a bird's beak appearance, or a pencil tip appearance, or abrupt cutoff. Everything is the same, but most importantly, the bird's beak is important. And what is this Hurst phenomena is, because there is a narrow pressure area. See here, the contrast is spilling like this. So this is known as Hurst phenomena. Hurst phenomena. Okay, that is Hurst phenomenon. This is the next level for us. Bird's beak is important, and next level Hurst phenomenon is also seen in eclasiocardia. You are just injecting under pressure. There is a small opening here. Under pressure, if you inject, what happens? It spills over. That spillover is known as Hurst phenomena. Okay. So, what is the investigation of choice?
Barium swallow study. Very
No,
good.
no, not barium swallow. Investigation of choice. I am asking you the investigation of choice.
Endoscopy. Yeah.
Manometry.
Manometry.
Yeah. High resolution manometry.
Manometry.
This is the investigation of choice. High resolution manometry. So, see here. This is the esophagus. This is the stomach. If you take a X-ray chest, what will be the finding? If you say an X-ray abdomen, what will be the finding? This investigation of choice is fine for you, right? Any doubt in this?
No, sir, IOC is fine.
Yeah. So X-ray chest. Just think, whenever food is there in the stomach, there will be gas fluid level. Okay, there will be fluid level, there will be gas, there will be difference. Gas fluid level will be there. Okay. Yes, no?
Yes, sir.
So tell me, what is the X-ray picture of intestinal obstruction? I think you all know this. If there is an intestinal obstruction, what will be there?
Step ladder.
Step ladder, okay. And multiple?
Fluid.
Gas.
Multiple, yeah, come on. Multiple?
Gas fluid.
Yeah, gas fluid levels are there. You know about it, right? There will be multiple gas fluid levels if there is some obstruction in the GIT. Same way, here there is obstruction in the esophagus. There is obstruction in the esophagus. So you can see in X-ray chest, you can see multiple gas fluid levels. Okay, behind the heart shadow. Heart shadow will be like this, overlapping. Behind the heart shadow, there will be multiple gas fluid levels. Okay? Clear?
Okay, sir.
Yeah. And there will be absence fundus gas shadow, because here only there is obstruction. So nothing is passing below. So normally there will be fundus gas shadow. Here the fundus will have a gas shadow normally. It is absent. So these two are our example. These two are the X-ray images, X-ray picture of our eclasiocardia. Are you able to follow?
Yes, sir.
Yes, sir.
Others also?
Sir, will you show images? These X-ray images?
Image I don't have actually.
Oh.
That image I don't
Or
have.
it's okay, sir. I'll check it out.
Yeah. Yeah, if image is there, you will understand better. But I think
Yeah, I'm a little confused. I'm not able to grasp it quickly. That's all.
so. See, this is not the exact image, but look at this. This is the chest here. This is the heart shadow. This is normal X-ray. You know that, right?
Yes, yes.
Yeah. Here, this is the esophagus, and here you can see some air fluid levels.
Okay,
Okay.
sir.
Yeah. And second thing is, if you take an X-ray of the abdomen, there will be a small air shadow, fundic air shadow. There will be there. That will be absent here because nothing is going below.
Okay, because of the obstruction.
Yeah.
Okay.
Okay. And Okay, now the least important, why etiology? Why will this eclasia be there? Why? What is the reason? Is because of the absence of ganglion cells. Absence of ganglion cells. Ganglion cells are absent in this region. So the constricted part is normal. Suppose this is the esophagus, this is the sphincter area. This area is normal, but the ganglion cells are located in this area, in the above area. Okay, so they are not present in the esophagus. Because of the absence of these neural cells, there is the sphincter will be failed to open. So the absence of ganglion cells in the constricted part. This is constricted part is normal. This the normal looking esophagus is abnormal. Okay, and this has a similar finding will be there in Hirschsprung's disease. Hirschsprung's disease. What is this Hirschsprung's disease?
Failure of migration of these cells, neural cells.
Yeah, it is also the same. If you study Hirschsprung's disease, it is almost the same. Okay, there is also ganglion cells are not there. Here also ganglion cells are not there. Ganglion cells are not there. So motility, it is a motility disorder. Okay, we'll deal with that also in the later class.
But what is the marginal difference between these two conditions, sir?
Yeah,
Because there
that's what
has
I
to
wrote
be
here.
something. Okay.
Yeah, constricted part is normal. Here the constricted part is normal in eclasia cardia, whereas the constricted part is abnormal in case of Hirschsprung's disease. Okay.
So this is the anatomical basis.
Yeah, this is the anatomical.
Okay, sir.
Yeah. So here the constricted part is normal in case of eclasia. The pathology lies above, but there in a Hirschsprung's disease, the pathology lies at the point of constriction only. That is a small difference, but rest everything is almost the same because of the absence of ganglion cells. Okay.
Okay, sir.
Yeah. So the complications, food is left behind in the esophagus for a long time. So what will happen? There will be esophagitis, reflex esophagitis. There may be aspiration. The patient may aspirate the food into lungs, or there may be sigmoid megaesophagus. The esophagus will be dilated, bulky. Okay, it is sigmoid megaesophagus. And the most common tumor is squamous cell carcinoma. Long-standing, what will happen? There will be formation of tumor formation also, malignancy, turn into malignancy. It is squamous cell carcinoma. These two are important. Most common reflex esophagitis, and the most common tumor is squamous cell carcinoma. So management, we are coming to the management. We have medical, we have endoscopic, we have surgical. There are three types of management: medical, endoscopic, and surgical. Okay.
Okay, sir.
So medical, what is this nifedipine? Which class it belongs to?
System and calcium channel block.
Calcium.
Calcium channel blockers?
CCB,
Yeah.
sir.
And sildenafil.
Antiphospholipid.
PDE5 inhibitor, right? It is a phosphodiesterase inhibitor.
Inhibitor.
Okay. So these two drugs can be given to relax the sphincter. Here the pathology is sphincter is not relaxing. To relax the sphincter, we can give these two drugs. Okay. And can you tell me, think logically and tell me that this is the problem. Okay. Suppose this, the sphincter here is contracting. It is tight now. You give drugs, it is not working. So what else can we do? To make the sphincter open, what else can you do?
Surgery can be done with.
Yeah,
Balloon,
before surgery.
balloon dilatation could be happen?
Yes, you can yes, very good, very good. So you can do a pneumatic balloon dilatation or give Botox injection. What is this Botox injection? Heard about
Botulinum
it? Botox?
toxin.
Yes,
It's a
sir.
Yeah.
botulinum toxin.
Botulinum toxin. Okay. If you give something, if you give a Botox injection, it will make the sphincter relax. Okay. So you can give a Botox injection. You can do a balloon dilatation, pneumatic balloon dilatation, or there is a technique called POEM technique. This is recent advanced POEM, peroral endoscopic myotomy. Peroral endoscopic myotomy. Okay, you just put a scope inside peroral, and this is the esophagus. You just give a incision there. You just incise the muscle there so that it will relax. Okay, it is known as peroral endoscopic myotomy. But these three things are success rate is around 50 to 60% only. The highest success rate is for surgery, 90 to 95%. So the best option to treat is surgery. Is this clear?
Yes, sir.
They may
Yes,
ask
sir.
you this poem. What is the full form of poem and in which disease is used? Poem is peroral endoscopic myotomy. It is used for eclasia cardia. What is notes?
Natural orifice.
Natural orifice.
Transluminal
Transluminal.
endoscopic surgery.
Yes, very good. So this is one type of notes only. Poem is nothing but it is one type of notes. Okay. So now you know the medical management, you know the surgical management. Sorry, you know the endoscopic management. So surgical management. So this is the esophagus, this is the stomach, this is the sphincter, narrow sphincter, it's not opening. So what can be done? Which surgery can be done?
Esophagectomy?
Esophagectomy. No need to go such radical thing, just because there is small, see here the pathology is, here there is a small problem.
Can we reconstruct it?
Yeah, you can reconstruct it. Okay. And suppose, see this, look at this, look at me. Suppose this is the tube. If you make a small opening, if you give a small incision, small cut, what will happen? It will open up. Yes?
Yes, sir.
If you give a small opening, it will open up. So what we do is, we do a myotomy. We do a myotomy. Myotomy. Inside is the muscle. Myotomy. Which muscle? Cardio. This is the cardiac sphincter. Lower esophageal sphincter is cardiac sphincter. Cardio. And the name for this is Heller's. Heller's cardiomyotomy. Yeah, Heller's myotomy. Somebody has answered. Heller's myotomy. Heller's cardiomyotomy. Okay. So you have incised it. So what will happen? After you incise it, will everything be good or something will happen in the future? If you incise and leave it, you have just incised the muscle and you left it like that. So what will happen?
Reflux would
contents will-
happen.
100%. 100% the patient will have reflux. You have corrected one problem, the patient will end up in another problem. So what you do now? So we have to correct that also. We will anticipate that and we have to do something else. So what we do?
Fundoplication?
Yes, we do a fundoplication. Fundoplication. That is, this fundus part is there, right? Listen carefully. This is the fundus part. So what we do is, this fundus part, we wrap it around the esophagus. We wrap the fundus part around the esophagus like this. Okay, just we'll wrap it and we'll suture it. This is fundoplication. Okay. So the treatment, you should never tell only Heller's cardiomyotomy. It is Heller's cardiomyotomy plus fundoplication. Is it clear? Yes, no?
Clear, sir.
Okay. So the fundoplication, see, suppose this is, again, look at the image here, look at me. This is the esophageal tube. This is the esophageal tube. Here the fundus is there. We will wrap it around. So the fundus can be wrapped anteriorly. The fundus can be wrapped posteriorly. The fundus can be wrapped 360 degrees. It can be wrapped to 180 degrees, 270 degrees, 90 degrees. Are you following?
Yes.
Yes, sir.
Okay. See, there are two tubes now. One is the esophagus, one is the stomach fundus. So to prevent reflux, I am wrapping it. I am wrapping it so that it will again form a tight junction. So that wrap can be a complete 360 degrees wrap or a 180 degrees wrap or a 90 degrees wrap. Just wrapping around, wrap. Okay. So depending upon it, they have so many named surgeries like Nissan's fundoplication, Doer's fundoplication, Taupet fundoplication. No need to go into the detail, but just understand the concept. Okay. We did a cardiomyotomy to prevent eclasia. So what problem did the patient land into? What
G.
problem?
Sorry, you didn't understand the question. What did you ask?
We did a myotomy, cardiac myotomy we did. So the patient will, for eclasia, we did this. So the patient will land into which problem?
That would be
Reflux disease.
reflux. That would be
Gastroesophageal
reflux.
reflux. To prevent reflux, what we have to do?
Fundoplication.
Fundoplication. Yes. The fundoplication may be anterior or posterior, and it may be 360, 180, or 90. Okay.
Just a question, the Nissan's fundoplication, is it the 360-degree one?
Yeah, Nissan's is a 360 fundoplication.
360 one.
And door we commonly do is doors fundoplication. This is the anterior 180-degree fundoplication. So it is, we bring the esophagus to one part and we'll close it. We'll bring the fundus to one part, only one half, and we'll close it. That is anterior 180-degree fundoplication. Complication is GERD. And for those who prepare for NEET, this one, ECARD score is the post-treatment score. Okay, ECARD score is a post. If you do a treatment and how is it, like how the patient is satisfied or how the reflex is there or not, for that this ECARD score will be useful. ECARD score. Okay. So now again coming back to the hypermotility disorders. Hypermotility disorders. Eclasia is clear?
Clear, sir.
Yes.
Yeah. What is bird's beak?
Bird's beak appearance for
Yeah, bird's beak
eclasia cardia.
Eclasia cardia, where? In barium?
Swallow.
Barium swallow.
Barium swallow. Okay. So this is about the eclasia. Then coming to the hypermotility disorders. Hypermotility, that is motility is increased. So there are two conditions. Diffuse esophageal spasm. The esophagus is contracting, diffuse esophageal spasm. And the other is nutcracker esophagus. Nutcracker esophagus. Okay, these are the two important hypermotility disorders. Okay. So look at this. Nothing much here. See, this is seen in middle-aged female. Middle-aged females. This is males are equal to females. And most common hypermotility disorder is nutcracker esophagus. This is the most common hypermotility disorder. Two hypermotility we are discussing. One is diffuse esophageal spasm and one is nutcracker esophagus. And see, the symptoms are, it is having dysphagia and chest pain. It mimics like MI. Okay, same like myocardial infarction. So medical treatment is calcium channel blocker can be used for both. What is that calcium channel blocker?
Like
Nifedipine.
Nifedipine. And for diffuse esophageal spasm, a myotomy, same like a long, see, this is eclasia, only the sphincter is done. So we give a small myotomy. This is diffuse esophageal spasm, complete esophagus is in spasm. So we'll give a long myotomy. But nutcracker esophagus, it is like this, nutcracker. I'll show you the image. So there is no surgery for nutcracker. And diffuse esophageal spasm will look like corkscrew esophagus on the barium swallow, corkscrew esophagus. While nutcracker esophagus, there will be a diverticulum. Why diverticulum? Because of increased pressure, there will be outpoaching from the esophagus. There will be a diverticulum like thing. Okay. So see here, see this images once. Are you able to see the images?
Yes, sir.
So see this diffuse esophageal spasm. You are having corkscrew esophagus. See this corkscrew esophagus on the barium. Corkscrew. And nutcracker, it is the hypermotility. Which hypermotility? Most common, least common?
Most common.
It is the most common hypermotility disorder. Okay, just remember these two images. That's enough. Diffuse esophageal spasm, corkscrew. Just remember this image. One.
So why is it more common in women, sir?
Which one?
Diffuse esophageal spasm.
No, I don't know the reason for that. But some problems are more common in males, some problems are more common in females. That's it. But no specific reason for that.
Okay, sir, fine.
Okay. Yeah. Esophageal disorders, thyroid disorders, they are more common in females. Thyroid we can explain because they are autoimmune conditions. But esophagus, we don't know why they are more common in females.
Fine, sir.